half-hour class. So we're going to try to do it in 50 minutes. You ready? So I think the way to learn hemodynamics and some of the general changes or things that you might see, especially in an acute situation, since all of you are in some sort of critical care, acute situation, just to be able to identify what is normal and then to be able to see what is abnormal so that you know when to alert somebody, when to intervene, when to act. So that's why I did a combination of our general A&P for cardiac and then hemodynamics. So our objectives for today is just to reaffirm that you understand what the structures, the function of the heart is, identify normals so you can identify abnormals, and then we're going to review hemodynamic concepts and then kind of shock states and what to do with them. So we'll try to rush through. At any time, please, if you have an example, if you have a question, raise your hand. We can talk scenarios. If you run across something in the last, few weeks in your own practice at the bedside that you have a question about, by all means, this is the place and space to do that. So again, just understanding the terms and the structure and function of the heart. When we're talking about the way the heart sits in the chest, about the size of your chest or size of your fist, sits over to the left a little bit behind the sternum. When they talk about what the apex and the base is, so the apex is actually at the bottom. It's the more pointed end, faces the left hip. So when we're talking about, you get a report or you see on an echo, they have apical hypokinesis. They have Takotsubo cardiomyopathy, which is an apical ballooning of the heart. They're talking about this bottom part of the heart, mostly left ventricle. So if you have a massive anterior wall MI, you can have apical hypokinesis, meaning that apex of the heart is not functioning and not squeezing as well. So knowing that, if somebody says they have apical hypokinesis, what kinds of things would you anticipate or be seeing? Potentially that patient is going to be could have cardiogenic shock, could have low ejection fraction, low blood pressures. So again, just understanding what those terminologies mean. Around the heart, we have the sac, which is the pericardium. So we have the parietal pericardium, the pericardial fluid, and then the visceral pericardium, which is on the outside. So typically you have the fluid that's in the sac. It just, every time the heart beats, it makes the two layers rub easily together, right? But then what happens when you get a lot of fluid collected into the sac around the heart? So in an acute situation, rapidly, as little as 200 mLs can cause hemodynamic compromise. So what's happening when the fluid is collecting in the sac around the heart? Equalizing pressure on all of the chambers. So normally you have atrium ventricle. You're able to fill the atrium by the venous return. When you have so much pressure on the outside of all four chambers of the heart, you don't have that same function, and you can have cardiac collapse. You can have hemodynamic compromise. This is a patient we had a few years ago. It was an older gentleman in his 80s. He was just complaining of some shortness of breath. They did an echocardiogram. They saw this huge globular heart, and we drained over 2 liters out of his heart with the pericardicentesis. He actually did very well, but that accumulated over time. I think in the end they discovered that he had cancer, and you can have pericardial effusions from cancer situations. So the other thing you might hear is pericarditis. So the inflammation of that sac around the heart. Sometimes the inflammation of the sac around the heart can lead to the pericardial effusion. So you may see someone come in with pericarditis, they do an echocardiogram, they have a bit of a pericardial effusion. Some of the things that you'll see, you can see EKG changes. Sometimes you'll have overall global ST elevations on your EKG. Oftentimes when they sit forward, they feel much better. They have relief from any pain. If they lay back and they're saying, oh, but now I have pain when I'm leaning back, maybe ask them to lean forward and see as the heart swings forward in the chest that they don't have the rubbing and it feels a little bit better. You might hear a pericardial friction rub. So that inflammation in there of the sac, you can actually hear like a grating sound when you're listening to them. So all things to kind of be thinking about. Also with the pericardium, pericardial effusion, you may get in report like they had a pericardiocentesis, a pericardial window. That's all discussing what's happening in the sac around the heart. The layers of the heart. So epicardium, myocardium, and endocardium. The epicardium layer on the outside, in CVU, we have epicardial pacing wires. So those are attached to the outer layer of the heart brought through the chest, and that's what we use after open heart surgery. The myocardium is that muscle layer in between. So if I know several of you worked through all of COVID, and viral myocarditis was a thing that we saw increasing during that big viral time. So tachycardia, pain can cause also some hemodynamic issues. And then the endocardium is the inner lining and the layer of the chambers of the heart. So that includes all the lining and all the valves. So you may have somebody say, well, they had endocarditis, which is when the vegetations kind of sit on the inside. Oftentimes landing and seeding onto a valve. So they can definitely have hemodynamic changes, hypotension, fever. You can sometimes have that splintering septic emboli where you'll actually see the spots on the fingers or the toes. Very sick. Night sweats, unexplained weight loss, and a new murmur. So when you listen to them and do your exam, if you hear wide open swishing, that could also be an indication of endocarditis. So TEE, which is the echocardiogram, transesophageal echocardiogram, look at the vegetation, either long-term IV antibiotics or a valve replacement is necessary. So 4 chambers, 4 valves. I'm not going to go through it all, but only to highlight on the right side of the heart, you have lower pressures. These are the numbers and the kind of concepts that you'll need to think about when you're talking about hemodynamics. The right atrium, low pressure to about 2 to 6 millimeters of mercury. All of your superior, inferior vena cava, they dump the deoxygenated blood into the right side of the heart. Right atrium dumps into the right ventricle. Again, it's kind of a thin-walled ventricle. It's pumping blood up into the lungs, which should have low resistance, right? Our pulmonary artery pressures aren't typically too high. So the pressure on the right side of the heart is about 5 to 25. Thin-walled, you can get the blood up into the lungs. After that's been circulated in the lungs, gets oxygen, dumps into the left side. A little bit higher pressure, but still low pressure on the left atrium, but then it goes down to the left ventricle. That systolic pressure is much higher. The LV is thicker. It has to overcome the vascular resistance of the rest of the body, right? Right side pumps to the lungs, left side pumps out the aortic valve, out through the aorta to the rest of the body. So you have higher pressures on the left side. We're going to talk about afterload. So we'll talk about hemodynamics and the all of the formulas for doing that. But when you think about the afterload of the right and the afterload of the left is the lungs. The afterload of the left is systemic pressures or stenotic valve. On the left, this is just one thing to think about. That mitral valve actually has these cords called chordae tendineae. So the blood passively drains from the left atrium to the left ventricle. So as in diastole, when the ventricle is relaxing, these cords help pull the mitral valve open. And then when the ventricle squeezes to push blood out through the rest of the body, if they hold the mitral valve closed so it doesn't backflow like this, okay? What happens when one of those cords ruptures? Yeah, one of the leaflets, you can have what's called a flailed leaflet. So typically that happens in an inferior wall MI. So if you have somebody with a massive MI, and then you get them from the cath lab, they've already got a stent to the RCA, you're recovering them, but then all of a sudden they become extremely short of breath. They're desatting, you listen to them, they have a new murmur, they just look like they are not doing well. it could be that one of those cords ruptured and now you have a flailed leaflet. So you would get an echocardiogram, take a look at that, and then it could potentially be a surgical intervention that needs to happen. But it is something to consider, you know, after you get patients that have had MIs. The heart circulatory system, I know you know this, there are two main arteries that come off of the aorta. So we always say there's three coronary arteries because we talk about the RCA, the LAD, and the left circumflex. It's actually the RCA and the left main, and then off of the left main branches off the LAD and the left circumflex. So there are two main arteries, but many branches off of them. It only really receives 5% of the cardiac output, but it extracts a lot of oxygen. So that heart muscle needs a lot of oxygen. So when we talk about not making the heart work so hard, doing a beta blocker, not letting them walk multiple laps in the hallway when they've, you know, haven't had any intervention yet. What you're doing is driving up the myocardial oxygen demand. If we have any suspicion that they have blockages or they need, you know, some sort of intervention, it extracts a lot of oxygen out of the blood, more than any other tissue. The other thing to know is that your coronary arteries actually fill during diastole, not during systole. So when the rest of your arteries are filling during systole, in diastole is when the coronary arteries are filling. So if you have a patient that all of a sudden becomes tachycardic, goes into AFib, and their heart is beating like this, what happens to your diastolic filling time? Cut it way down. There's no blood filling into the ventricles, right? And then there's no diastolic filling of the coronary arteries. So when people become tachycardic, they could also experience chest pain, shortness of breath, but their coronary arteries aren't filling as well because you have decreased their diastolic filling time. So if you have somebody that goes into rapid AFib, they become hypotensive, you get very nervous about giving them anything because their blood pressure is low. But if you don't slow down their heart rate, then you're not going to catch up necessarily with blood pressure either, because you need to fill those coronary arteries. Your MAP really needs to be above 60 to get the coronary arteries filled. So code situation, you're doing CPR. You want to make sure that you get good depth so that you're creating a pressure of at least 60 or above so that you can fill the coronary arteries while you're doing it. Main arteries of the heart we already talked about. So it's the right coronary artery and the left main branching off the RC or branching off the LAD and the circumflex. So this is just a picture of one of our valve procedures that we did. But if you see on the left side of the screen, that's your RCA coming off. Then the little branch is the left main and then branching off into the circumflex and the LAD. So that's where it comes off of the end of the aorta. The other determinants of adequate circulation. So one, we're going to talk about cardiac output, stroke volume times heart rate. But we also have to think about blood pressure, which is your cardiac output and your peripheral vascular resistance, your arterial resistance, blood volume, capillary dynamics, pressure gradients. So there's lots that go into what the circulation of the, you know, how we circulate blood around the heart, and lots of ways that we can manipulate those things. And then the electrical system. So we have plumbing and we have electricity. So all the electrical activity of the heart, the cardiac cells have automaticity. So they have the ability to spontaneously depolarize and create an impulse, right? So at rest, the cells are sitting there polarized. They've got all this energy. They're just waiting to release that energy. And that's what causes the pulse to happen. Able to respond to a pulse and then able to transmit pulse from cell to cell. The whole point of it is for contractility, right? If you don't have this electrical impulse, you can have an electrical impulse, but if you don't have mechanical capture, then what do you have? You have PEA, right? You have pulseless electrical activity. So you can have electrical signals coming out of the SA node, AV node, you know, ventricles. If you have nothing, if that's not causing anything mechanically to happen, then it doesn't matter, right? So that's the whole intended outcome, is for contractility. So electricity and plumbing. When we talk about the electricity and the nervous system of the heart, we have sympathetic and we have parasympathetic. And I think you probably have all, how many of you have pulled sheets? Did any of you pull sheets? So when they come up from the floor and they have a tube, a sheath still left in their artery or vein, and we have to pull that, so we have to hold manual pressure. You have vein, artery, nerve. You're holding pressure. All of a sudden, the patient starts yawning, and then like, I don't feel so good, and then pale. And if you have the benefit of having a monitor right there, then you see the heart rate start to go down. And then if you run a blood pressure, the blood pressure starts to go down. What are we doing? We're stimulating the vagus nerve. They're having a vagal reaction. So I will tell you, if you're ever pulling a sheath or you have a patient in a situation and yawning, be very careful. Just perk up if you see them start to yawn, because it's all going to come after that. Now, you can't always like let up off of where you're holding, right? So we're holding large arterial sheath sites. So atropine, fluids, getting their head down, all of those things. But what you're doing is stimulating their vagus nerve, right? Sympathetic nervous system, we can drive that up with all kinds of things. Patients are nervous in the hospital. I don't know, we give them medication, fear, fever, all of those things that just drives that heart rate right up, right? We're not going to go over this. You know how it goes. SA node, AV node, ventricles. SA node 60 to 100 is normal. AV node 40 to 60, ventricles 20 to 40. So what's cool about the heart is that if it doesn't see a signal from above, it will start doing it itself all the way down. But you do not want the ventricles to be the sole pacemaker of the heart. So if that's the case and you're in complete heart block, then you would definitely need to have either a temporary pacer, external pacer. And again, if you decide to externally pace somebody and you're looking at the monitor and you see a spike and a wide QRS, which is what you should see, do you necessarily have capture? Do you necessarily have mechanical capture? You do not. So as you're turning up your MAs and you see a spike and a wide QRS and you're like, awesome, somebody better put their finger on a pulse. So either radial pulse, carotid pulse, do you have mechanical capture of your electricity? So that goes for external pacing, that can, go for, transvenous pacing, whatever. You have to make sure that you have mechanical capture after your pacing. Okay, everyone's waiting for hemodynamics. So what's the point? What is the goal? It's just to maintain global oxygen and nutrient delivery, honestly. Do the cells get what they need? Do they get the oxygen? Do they get the blood? Do they get the nutrients? And by monitoring the hemodynamics, we can have evidence, or we can see if we're actually doing that for the patient. But I do want to say, and there's a slide about this, you don't have to have some sort of monitor necessarily to know if that's happening with your patient, right? Are they warm? Are they dry? Are they mentating? Are they peeing? So are all the functions of the body, when you walk into a room, if there's something not right with your patient. If that patient is like taking off their leads and their gown and their whatever, and they're just agitated, that could potentially mean that they are not perfusing well. You go in after 4 hours and they barely have any urine in their Foley catheter, or they haven't peed, but you get to the end of your shift and you're like, oh my gosh, has Mrs. Smith gone to the bathroom this whole shift? Like, maybe I should go in and check on them. You go in for your vitals and all of a sudden you see that their blood pressure is low, and you're putting all of it together. Like, they haven't been acting right. They're a little bit clammy, sweaty. Those are ways that you're monitoring how well this is happening in your patient. So you don't have to have the monitor, but we have the advantage of having monitors. So hemodynamics, cardiac output. So cardiac output is the amount of blood ejected by the left ventricle in 1 minute. Normally that's 4 to 6 liters. 4 liters on me is going to look different than 4 liters on Dr. Rickelman, right? I mean, it will be sufficient for me. It would not be sufficient for him, I don't think. So we have to look at what's called an index. So we take the cardiac output divided by the body surface area. We do that all the time in CVU. Before the patient comes up from the OR, we need to know height and weight. We put it into our PA Swan monitor, and then that gives us a body surface area. It gives us the cardiac index. So that's what we're going by. So cardiac index of, we go by 2.2 to 2.5. Okay, now we know that's sufficient. So if I have an index of 2.2, Dr. Rickelman has an index of 2.2, we know that we're both getting the output that we need, and that's sufficient. In the formula for cardiac output is heart rate times stroke volume. So heart rate, we know, tachycardic, bradycardic, here's our heart rate. Our stroke volume, there are many components of a stroke volume. So you have preload, afterload, and contractility, and that's what makes up your stroke volume. So you can manipulate this formula by what you're doing. So you can slow down the heart rate, you can give more volume, you can decrease the afterload, you can increase the afterload. So if you know this formula and you're looking at your patient, it can help you figure out what to do for your patient and how to correct your hemodynamics based on these formulas. So heart rate. Sometimes we see that the heart rate is going up, right? It can be a compensatory mechanism. Let's say you had a patient that just ran the bridge to gap race or whatever, Hannibal Cannibal that comes up in July. They come in, they're a little bit hypotensive, they're tachycardic. What do you think has happened with them? They're hypovolemic, right? They've sweated it all out. They're got dehydrated, but their heart rate can be driven up because their overall volume is down, right? Sometimes you can see, and we don't all have the liberty of sitting around a cardiac monitor and watching the heart rate start to go up, right? Like you're just sitting there and like, oh, I see Mr. Jones's heart rate used to be 70, but now it's 90 to 100. If you do, great. Why don't you go in and take a blood pressure, just see what is happening. But if you look at your trend over time, it might be something that you pick up on, that their heart rate is going up, their blood pressure is going down because it's compensatory. Causes of being tachycardic, you know this. Hypovolemic, low blood pressure, anxiety, fear, pain, fever, or exercise. So what do we want to do? If our heart rate is too high, we want to slow it down, right? So either that's by giving volume, that's by giving a beta blocker, that's by intervening in some way, taking care of whatever these causes are, then you'll get your heart rate back down to where you need it to be. Your stroke volume is the amount of blood ejected with each contraction. It's usually about 60 to 100 mLs is what's being contracted out with every beat. You don't eject out everything that's in your ventricle. You do have some that's left over. The preload is the volume or the pressure that's in the ventricle at the end of diastole. So just right prior to ejection. So as the heart's relaxing, the atrium contracts, they put 25 to 30% more blood into the ventricles. Then the ventricles are going to squeeze, right? That's your preload at the very end of diastole. On the right side of the heart, we can look at that by your central venous pressure. Your CVP is actually looking at your right atrium, but there's really not a great way to get down and look at your right ventricle. But in diastole, that valve is open. It's reflecting through an open valve to the end of diastole, so you can get a back reflection of what that pressure is, and the same on the left, a pulmonary artery occlusion pressure, which is a wedge pressure. In the CVU, when we use our swans, we can look at a pulmonary artery diastolic pressure, and that is reflective of what your preload is on the left. Your afterload is your pressure or resistance in the that the ventricle has to overcome to pump blood out of the body. So on the left side, if you have high blood pressure, you're really tight and squeezed down because you're vasoconstricted for some reason, then your afterload goes up. It's much harder for the ventricle to push blood out over that kind of resistance. The other thing that can happen is if you have like a stiff valve, like a stiff aortic valve, that's kind of a fixed afterload, and your ventricle is working really hard to try to get the blood out. In the right side of your heart, the lungs are your afterload. So if you have high pulmonary pressures, if you have a PE, if you have pulmonary edema, all of a sudden it's much harder for the right side to get blood up into the lungs, right? Because you have that back pressure coming back on. And then contractility, which we have already just talked about. How well is the heart squeezing? So decreasing preload, you have a hemorrhage, you have a trauma come into the ER, they've already lost a lot of blood with decreased preload there. Diaphoresis, vomiting and diarrhea. Third space loss. You can have venous dilatation, right? So what's dumping blood back into the heart? Inferior vena cava, superior vena cava, your venous return to the heart. So you've just given them nitro for chest pain. But then they say, I have to get up and go to the bathroom. Okay, so you stand them up. What happens? Right, you've just dilated their veins, decreased their preload, they stand up, they get orthostatic, right? So they don't have the venous capacitance to squeeze that, to shunt the blood back up. So, I mean, we do things with our patients all the time that manipulate these things. Shock, septic shock, neurogenic, and anaphylactic shock, they just don't have the ability to compensate and to squeeze. Increasing preload, IV fluids or blood, we use that a lot because we want to increase preload. Sometimes renal failure with fluid retention, the venous constriction. So if you're hypothermic, you will constrict, right? Alpha stimulants like pressors, and then shock, cardiogenic shock and hemorrhagic shock, those are compensatory. So then the body constricts the blood vessels and it increases your preload, and then positioning, right? So when you do the passive leg raise, or you put their head down, or you put them in reverse Trendelenburg, you're trying to passively get the preload back up to the heart. Okay, what increases our afterload? Arterial constriction, right? So if you have systemic high blood pressure, if you have compensation for hemorrhage, like we just said, all of your blood vessels constrict, or pulmonary hypertension, and that's the increased afterload for the right side of the heart. We do this on purpose with drugs like Levophed, Epi, dopamine, vasopressin, Neo, or you can have a stenotic valve. So either you have a stenotic pulmonary valve or pulmonic valve, or you have a stenotic aortic valve. Decreasing afterload, hypoxemia actually will cause vasodilatation when you'll have decreased afterload. Shock, septic shock, neurogenic, anaphylactic, all the drugs we use. Nitro, nipride we use a lot in CVU, calcium channel blockers, ACE inhibitors, and morphine. So all those things will vasodilate and you can decrease your afterload. So if you need to decrease your afterload, if you're really having poor cardiac output and the blood pressure is really high and you are trying to manipulate that, these are things you can get in order for nitrohydralazine, morphine, something like that. Let's say you have a patient that had an anterior wall MI. They are going into cardiogenic shock. Their preload is elevated because their anterior wall is not working, right? So their left ventricle is not squeezing as well. So instead of moving the blood forward, it's moving backwards. You now have increased pressure in your lungs, increased preload on the right side, but decreased output from the left. So the body says, uh-oh, I have decreased output. I'm going to constrict everything, right? So how do we decrease preload, decrease afterload in order to offload the heart so it can work easier? So you could give Lasix, morphine. You could give something to dilate on the left side. So you'd have to manipulate both sides in cardio. Do you give like an inotropic medication to help squeeze the heart better, but then vasodilate so that you're decreasing the afterload? So lots of ways to manipulate that. And then who knows what this is? This is a balloon pump. So this is what you would see probably in CVU, ICU if it had to go there, but I don't know that they love it when it goes there. A balloon pump is a mechanical means of decreasing afterload. So what it is, it actually sits in the aorta, and then right before the heart beats, the balloon deflates, makes it much easier for the left ventricle to move blood forward. So it decreases the afterload that way. It also increases coronary perfusion by augmentation. So it also, when the balloon inflates, it augments the blood flow through the coronary arteries. So, and then your contractility. So your ejection fraction. So we talk about stroke volume, but then a lot of times we just talk about ejection fraction. So when you get a report, you're like, oh, they only have an EF of like 30%. They only have an EF of 20%. They may need a life vest. Where they're on diuretics because, you know, they constantly have heart failure because their left ventricle doesn't work. How you calculate that is actually the amount of total blood in the ventricle, and then how much is actually pumped out of the heart. So if you have 130 mLs, but you actually pump out 65 mLs, your ejection fraction is 50%. You're ejecting out 50% from what was in your left ventricle. So we calculate that with echocardiogram, but it gives us a good idea of how well that heart is pumping. So normal is 50 to 65%. Anything less than 30, one, heart failure. Two, can be they can have be proarrhythmic, and so you may think about things like a life vest in case they have any kind of ventricular arrhythmias. And that all comes from the doctor. And then Starling's law. You know, if you stretch it, you give them preload, you stretch it, you can have better cardiac output, better contractility, but that's only to a point. You overstretch it with somebody with heart failure, and then it doesn't snap back. So you don't really get any benefit from overfilling. It's just filling to the point that you get that extra stretch, gives you increased force when it is contracted. Okay, ways to measure, which we already talked about. Your assessment, which is great at the bedside. You know your patients, you're going in, you're seeing how they are. Cool, clammy skin, pale, diminished bowel sounds, which I don't know how many of you are just standing there with your stethoscope listening for bowel sounds for all the time that they tell you you're supposed to. That might not be my first assessment, but if they happen to have an NG tube, you may see that they actually have extra drainage coming out of their NG tube because their gut's just not working. And so that GI fluid just builds up, and then you'll see more. Decreased urine output, increased respiratory rate and effort, and then that altered level of consciousness where they just get very picky and, you know, restless and all that. And then invasive monitoring tools, which is our favorite because we can see everything from minute to minute, arterial line, CVP, and pulmonary artery catheters. So is PCU using any invasive lines? Are you can still get our lines. And do you have central lines that you could hook a CVP up to? Have you ever? Yeah. Okay. So the nice thing about having a central line is that you can actually connect transducer tubing, typically to the brown port, hub to hub, and you can actually get a tracing, right? And it will give you an idea of whether your patient is too wet or too dry. The thing about doing any sort of monitoring with transducer tubing is that it has to be correct. Like the data has to be, you have to be leveled in order for the data to be correct. So you're leveling to the phlebostatic axis, which is mid-axillary line, fourth intercostal space. So when they're laying down and your transducer is right, then your number is right. But then you sit them up to eat and you haven't done anything with the transducer, then your numbers are not correct. So one of the dangers of doing that is somebody's covering you for lunch. They walk by and see like, oh my word, their blood pressure is 69. But they're sitting up eating and everything is fine. It may not be. So make sure if you're going by that number on the monitor, that you are making sure that that is correct. What happens if the monitor, the transducer, is above the level of the heart? What does it do to your blood pressures? It's down. So if your transducer is up here, your blood pressure reflected on the monitor is going to be low. If you lower the transducer, the number on your monitor is going to be high. If your number on your monitor is high and you just want to fudge the transducer because you don't, you want to make your numbers look better, you can like move your transducer. I don't recommend doing that, but you can, if you know the doctor is coming and you want to make sure your numbers look good, you just fudge that transducer a little bit. You're like, things are fine, it's under control. And then you hurry up and fix it. But then you can correlate that with a blood pressure cuff. And if you're using a transduce line, you don't need to do a cuff pressure every 15 minutes. That's what your transduce line is for. So do it every hour and make sure that they are correlating. But other than, or if you have a problem, then check it, but you don't have to do it all. The only reason I put this up here is just to show you the advantage of having a line. So if you work with art lines a lot, ICU, CVU, there are certain things that your art line waveforms can tell you. So it's not just for frequent blood pressures. It's not, to watch blood pressures or frequent ABGs. There are actually waveforms that show you if something is happening. So before we talked about cardiac tamponade, when all of the chambers of the heart get pressurized at the same time, if you have an art line, you can actually see something called pulsus paradoxus, where you have a tall waveform, and then with respirations, it drops down and then goes up. We don't have to go into that today. That's into the weeds. But just so you know, there are, if you really want to get into it, there are things with your waveforms on the monitor that can clue you into something that's happening or confirm something that you suspect is happening. Your central venous pressure of your right heart. Again, if you have the advantage of having an IJ line in or subclavian line in and you have transducer tubing, look it up. If you have a patient that you're not sure like how they're doing overall, or you may have over diuresed them, or you think they need diuresed, or just something doesn't seem right, get a number. You don't even have to leave it hooked up all the time if you don't want to. You can still use it for other reasons. But the CVP in diastole, it's equal to your RA pressure. So that will give you an idea. And what did we say the normal RA pressure was? Does anybody remember what kind of number you're looking at? 2 to 6. So you're kind of just looking in those single digits. If you have a CVP pressure that's, 15 to 20, and actually we kind of like them that high in CVU, but if you're starting to have really high numbers, then you'd be concerned that, maybe they have a little bit too much volume. You may need to diurese them. Or if you do a CVP and their blood pressure is low and your CVP is -1 or 2, which it can be, then you need to give your patient volume. You can also do that with your Starling monitor, right? So the Cheetah monitors you can get on and it will tell you, and you can do passive leg raise, you can do full fluid bolus testing just to see if that's what you need to do. Do you guys ever use flow tracks anymore? Vigileos in ICU? Not really. Yeah. Now that we have bigger and better things, so we don't always have to. Did you? I'm going to take that right out of my slides. Yeah. Perfect. Yeah. For people online, we were just talking about getting rid of flow tracks.
Yeah, give the hope is about the ones.
Okay.
We'll still use them, but they've always brought their own.
Yeah. Okay. Yeah, that Starling monitor is really nice. So invasively, we can use PA pressure, PA catheters, which we use all the time in CVU. I don't know how often, other than gift of hope patients, sometimes they will put PA catheters in, but it gives you PA pressures. It gives you, it's been a lock. Oh, well. It gives you PA pressures, CVP, cardiac output. We have cardiac output swans, so it calculates all of that for us. Goes in right atrium, right ventricle, and then goes up into the lungs. So the end of the catheter is sitting up in the pulmonary arteries. When we talked earlier about how you see what the left ventricular and diastolic pressure is, you have to either take the pulmonary artery diastolic pressure, which kind of back reflects, or you can do something called a wedge pressure, where you actually wedge the tip of the catheter into the smaller capillaries of the pulmonary artery, and it can give you a number that reflects the left ventricle, and that gives you kind of what your left-sided pressures are. It's a lock. Sorry. 1 second. This is what it looks like on x-rays. You'll see the PA catheter come down and loop around. And these are this is kind of the screen that we look at when we're like post-open heart monitoring, let's say. So we have your EKG, art line, PA pressure, CV pressure. So we can monitor it beat by beat and change hemodynamics that way. So our cardiac, continuous cardiac output monitor also gives us what we call an SVO2, which is a mixed venous oxygen in the blood. So it can also tell you what's happening with your patient as far as are the tissues extracting the oxygen that they need? Are they extracting more oxygen than they need or not enough? So when you talk about different shock states or things that are happening with the patient, so normal is 60 to 80. When that number, when you see what the mixed venous oxygen is, if it's 60 to 80, then you feel like things are okay. If the oxygen has been extracted, so you have less than 60, then what's happening with your patient? Do they have a fever? Are they tachycardic? Are the tissues extracting more oxygen than they need? If it's also, if the cardiac pump is not working, so your left ventricle is failing to pump well. So you can have a lower mixed venous oxygen that way. Is the blood oxygen content low? So is something happening in the lungs that the oxygen, blood is not getting the oxygen, or your level of hemoglobin? So especially in CVU, we can check chest tubes. So if they have their chest tubes are full and we know that they've lost a lot of blood, sometimes that can drive down the SVO2 as well. So that's just another number in hemodynamics that we can look at. I just want to go over that systemic vascular resistance as well. So when you're looking at cardiac output and SVR, they are kind of a teeter-totter. So if your vascular resistance is up, like I said, it's much more difficult for the left ventricle to get the blood out to the rest of the body. So it is a teeter-totter. Once you decrease your SVR, you have a better cardiac output. Or if you increase your cardiac output by fluids like preload, gives it more strength to overcome the afterload, then you have a better blood pressure as well, or better cardiac output. So those are in a seesaw teeter-totter relationship. All right, let's look at this. We're almost done. In hemodynamics of shock. So you'll all experience some sort of shock in the patients that you take care of. So hypovolemic shock, when we look at their preload, we know that their preload is going to be down, right? They don't have the volume in their body to fill. Cardiac output is actually high because they're trying to compensate. And then your SVR afterload is also high. That's the compensatory squeezing or constricting of the vessels. And then what do? You fill that space, right? You give them IV fluids, you give them blood if that's what they need. In cardiogenic shock, actually your preload is high, and that's because the left ventricle is not working, right? Or your right ventricle if you're in RV failure, but your preload is high because it's not pumping as well. So your cardiac output is low. Your afterload is high, again, with the resistance. So you can do inotropes, or if you think that there's a reason that they are all of a sudden in cardiogenic shock, like an MI, then you can go and do revascularization and open up the lesion that may be causing the problem. Distributive shock is like septic or neurogenic shock. So their actual preload is low, so they vasodilated, all the fluids have gone into the capillaries, into the tissues. Wedge is low. Their cardiac output is high, again, just trying to compensate. And then their afterload is low, again, with all the vasodilation. So you give pressors and IV fluids. Okay. On to the case examples we're going through. Poor Andy had a large anterior wall MI with sustained hypotension. His blood pressure has been less than 85. He has a low cardiac output, due to poor contractility, which makes sense. If you have an anterior wall MI, that's your left side. So it's left anterior descending artery usually. Anterior wall MI affects your left ventricle. Low cardiac output due to poor contractility, elevated preload to the left side of the heart, and an elevated afterload. Or anterior, these are just bonus questions from a different class, but anterior wall MI, what artery do you think is the culprit? It's okay if you don't know. What? LAD. So your left anterior descending would be the culprit artery. On your EKG, it's usually V3, V4, it can potentially be V1, V2, V3, V4. Elevated preload of the left ventricle would be seen in which number? What are we looking at? If you had invasive monitors, what number would you look at to see that your left ventricle was had elevated preload? On the left side of the heart. Yeah, so it would be your pulmonary artery pressure, most likely your PAD, pulmonary, or your occlusion pressure, like a wedge pressure. Symptomatically, what do you think you would see? If your left ventricle is not working, your preload is high, the fluid in your left ventricle is not moving forward to the rest of your body, where is the fluid going to? In your lungs. So how do you think that should practice? Decreased oxygenation. In order to optimize Andy's preload, you may want to use a what? We want to decrease his preload, what would we use? The diuretic. So let's hit him with some Lasix. And then elevated afterload as the LV is reflected in which number? This is all. I mean, it's just, it's hard. It's SVR, yeah, systemic vascular resistance. So it's all the resistance after that part. In order to reduce Andy's afterload, what would we use? Not a yes. What would maybe say? Vasodilator. You want to use a little nipride, a little nitro, something. But in order to help Andy with contractility, what kind of medication would be beneficial? An inotrope. We're going to do an inotrope. And actually, there are some inotropes, milrinone and obutamine, that actually are a bit of a vasodilator anyway. So you can actually use them for the squeeze and they'll vasodilate. But we're going to help Andy out here. Your next patient, poor Joe, he has a necrotic bowel. So he's febrile, high white count, cardiac output is 9.6. Blood pressure is low at 68/40. SVR, which is your afterload, is 480. Is the cardiac output low, normal, or high? High. Is the afterload low, normal, or high? The afterload of 480. We didn't go over that. It's actually low, right? Exactly. What type of state would you say the patient is in? Septic shock, exactly. In order to obtain adequate arterial perfusion, you may want to add what type of a medication? Exactly. Okay. In 50 minutes, we just flew through all of that. And I know it's very hard to do like a high level, any of it. So if you want to actually go through, if you have patients or you want to go through hemodynamics, like step by step, a little more in depth, I'm happy to do that with you. I do them like sort of one-on-one or two, people in two people sessions. It's much easier really to do like the in-depth stuff, not in a high overview. But what questions do you have, or what situations have you had that you need to talk about? Yeah, so Sometimes you have to escalate and add pressors to it. So that would you say you're in PCU? Yeah. I don't know how many you're allowed to use. Just levo.
We have to.
Yeah.
Sergeant.
Yeah.
That's only pass, and one is a better to answer this.
Yeah. So the question is, if they see a lot of septic shock, and if at what point do you either add levo or use something else? Not knowing what all your protocols are, so you need a perfusing pressure, a mean pressure of over 60 to 65 millimeters of mercury in order for end organ perfusion. So if you are titrating up your levofed and you are not getting a MAP pressure of 65, then you either need to add something else. I don't know, in septic shock particularly, levofed's a great option, so I don't know that changing it's going to do anything, but adding like a vasopressin or, adding another, I think at that point you need to consider transferring to a higher level of care. I don't know if you would say anything different, Shannon, but I mean, I think if you have somebody like that and you are concerned, it is worth sticking around and repeating blood pressure. So mean arterial pressures less than 60 for over 20 minutes can already start to cause end organ issues. You'll see a creatinine rise, you'll see issues start. So it's not really, and it's really hard when you have 5 other patients that you're trying to take care of, but it's worth sticking close, repeating blood pressures, titrating levo as you're allowed to do. And if it's not getting that pressure up, if you need to give, are you allowed to also do fluid boluses and all of that? So yeah, septic shock is, sepsis is get the antibiotics in, get the fluids in, get the pressors on, and you have a short window to get the blood pressure map up where you need it to go before you cause kind of damage and spiraling down. 20. Anything else? You can get a hold of me. I'm on Volts. You can email me. You can text my cell phone if you have a question. I'm back and forth from the clinic to the hospital all the time. So, I mean, at any time, or if you see me in the hallway and you just have a question, we can talk about it. So. Okay. You're welcome.